and the recording will be posted on the committee's webpage shortly after the meeting. And now I'd like to invite Pam McEwen, FTAC Liaison to the Universal Healthcare Commission, to call the meeting to order. Pam?
Hey, good afternoon. Thank you, Angela. Welcome, members. It's now a little bit after 2, and it's time to call the meeting to order. This is FTAC's September 14th meeting. As we always do, I'm going to begin with a land acknowledgement from Seattle. And I would like to acknowledge that I am on the traditional land of the first people of Seattle, the Duwamish people, past and present, since time immemorial. And we honor with gratitude the land itself and the Duwamish tribe. I'd like to give an overview of the agenda, which I think will be displayed right there. So we're going to begin, as we always do, with roll call. And we would like to use this opportunity for committee members who we only know each other through Zoom. So this is an icebreaker to help us get to know each other a little better. This was what was your favorite movie that you saw this summer? Then we'll move on to vote to approve the July meeting summary, which will be followed by public comments. HMA will share where we are with our work plan, and then we're going to continue the in-depth discussion on ERISA. First, we'll be hearing from Bill Kramer of the Purchasers Business Group on Health, on potential employer purchaser perspectives on state-based universal healthcare system. Then we're going to be hearing from Aaron Fuse-Brown from the Georgia State University College of Law on ERISA considerations for Washington. We'll be having a discussion and taking a vote on ERISA recommendations to bring to the commission. And finally, towards the end of the meeting, HMA will share updates from the commission on their guidance on Medicaid. This is a very initial discussion. And I want to encourage FTAC members, as always, to ask questions and provide feedback as we go along to help facilitate today's discussion. I'm going to turn it over to Angela now, who will call the roll.
Thank you, Pam. Please remember when your name is called to let us know what was your favorite movie you saw this summer. There were some really good ones out this summer. We'll go ahead and start with Pam.
Thanks. I'm here, and Barbie.
One of my favorites too.
Yes.
Thanks, Pam. Christine?
I'm here too, and I didn't get to see a whole lot of movies this summer, but I guess I would say Asteroid City based on the ones that I've seen.
Ooh, okay, that's one for the list. Thanks, Christine. David.
Yes, I'm here. Good to see all of you. I had the most fun at the Mission Impossible movie, which I can't remember what that's called.
Which number Mission Impossible? We don't remember anymore.
Yeah, lost count.
That was a good one. Thank you, David. Eddie? And Eddie did let me know he wasn't going to be attending, but just for the record, Eddie? Okay. And Esther? Esther? Okay, Ian?
Ian Doyle, Assistant Liaison for the Department of Revenue. I would probably say Oppenheimer.
Also a good one. Good movies this summer. Kai?
Yes, hello, I'm here. I rewatched an old one called The Big Short.
Oh, that's a great movie. Yes. It's a good one, Kai. Thank you. Robert or Bob? Bob? Okay, and Roger.
Good afternoon. I'm gonna follow Christine. I think of movies. I liked Asteroid City. I'm kind of a Wes Anderson fan, and it fits into a good Wes Anderson picture. So.
Oh, nice. Okay, 2 Asteroid Cities. That's good. All right. Thank you, everyone. I'll turn it back over to Pam.
Okay, thanks, Angela. This is a good movie crowd. So please join me in turning to the second tab in your materials. And the recording of the last meeting is posted on our webpage. We'll use the consensus process for a vote on the approval of the July meeting summary. Is there any discussion of the meeting, any proposed changes or concerns? Okay, hearing none, I propose that minutes are accepted without change. Any discussion of this proposal? All in favor say aye.
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 I
I think we got through the group. Any opposed? And the notes are approved by consensus. Next, we'll move on to public comment. Committee members can find written public comments under tab 3. And we allow individuals to sign up to provide public comment before the meeting. And we will start with those that have signed up to provide comments. When you're called upon, please state your name and affiliation if you have one before speaking. And we will be displaying a timer at the reminder of the 90-second time limit. When the timer stops, please stop your public comments. Angela, would you please start with the names of individuals who have signed up to provide comment?
Sure thing, Pam. And just a note for members of the public who wish to provide public comments but would prefer to submit those comments in writing rather than giving them verbally here, FTAC has its own inbox separate from the commission. So if you'd like to make sure that that FTAC members are the recipients of those comments, we encourage you to send your comments to the email address on the screen, which is hcauniversalftac@hca.wa.gov. Thank you. We have 2 people signed up for comments. First, I have Roger Collier, followed by Catherine Lewandowski. So Roger, would you like to come on and provide your comments?
Okay, I hope I'm now unmuted.
You are.
Okay, good. So, good afternoon. I have 3 questions, 2 for Professor Fewes-Brown. I'm delighted to see us making a presentation, and 1 for this committee. So first, for Professor Fewes-Brown, incidentally, I asked the same questions at the July meeting, and I'm still hopeful. So first question, based on Kaiser Foundation employer benefit data, a single payer payroll tax of 9 or 10% would double healthcare benefit costs for some employers. What's the risk of triggering ERISA preemption as exorbitant? And your chart 10, talking to Professor Fewes-Brown now, tends to dismiss this, but it doesn't consider the wide range of current benefits or the wide differences in current coverage in uptake. Second question, if a single payer plan faced an ERISA-based lawsuit, then based on other ERISA cases, I estimate it could take up to 4 years before a final federal court ruling, possibly on top of a couple of years for state court deliberations. Am I close? And then for this committee, given the discussion in Professor Fewes-Brown's charts of a comprehensive public option, will this committee give me a few minutes at its next meeting? This is the ask now. Will this committee give me a few minutes at its next meeting to discuss the public option proposal that I submitted back in April? This might balance the presentation of a single payer plan proposal at a recent commission meeting. So there's the question. Thank you very much indeed.
Thank you, Roger. Next, we have Catherine Lewandowski. I don't see Catherine in the attendees list, but I'd like to just call out Catherine Lewandowski. Okay, I see Whole Washington. So I'm going to go ahead and promote you to panelists since we're still within the public comment time and we've finished with those who've signed up. So I'm going to go ahead and promote the person signed in as Whole Washington to panelists. So hang tight.
Yeah, that's me. I'm sorry. I was.
Oh, that's okay. Oh, good. I'm glad, Catherine. Thank you.
I don't have access to me on the thing to be able to change it that I'm aware of. Anyway. Hey, so my name is Catherine Lewandowski. I'm a registered nurse here in Washington State for the last probably 38 years. And I am also the co-chair of Whole Washington. And I just wanted to make a few comments to say that we really appreciate the time that we were able to present to the Universal Healthcare Commission. And we really hope that the members of this committee had a chance to watch that presentation, but also to let you know that we would love to delve deeper into the financing aspects of the Washington Health Trust with you. And we know there are some positive changes that we can make. And we have questions too, especially with like the capital gains tax portion and how that is affected by the current capital gains decisions that were made with the state. So I just want to say we thank you for your work and we would appreciate being able to work with you on this. Thank you. You guys have a great day. I have to work tonight, so I'm going to have to watch the meeting later. Okay. Thank you.
Thank you, Catherine. Next, I see Lori Bernstein. You have your hand up. Will you accept the invitation to join as a panelist? I'm going to resend that to you now so that you can provide your public comments. Lori, are you available to come off mute?
Sorry about that. Yeah,
No,
actually,
not at all.
that was an accident. I just meant to say that I think whole Washington, probably Catherine, but as long as you're giving me a moment to speak, I will just echo what Catherine said about if you haven't had the chance to watch the presentation that whole Washington gave at the UHC meeting, I hope that you will take the time to do that. So thank you that, and thank you for your work as well.
Thank you, Lori. Okay, and we'll give it just another moment to see. Oh, Maureen. Okay, Maureen, I'm going to promote you to panelist, so hang tight.
Thank you. My name is Maureen Brinklin, and I didn't get signed up, but I would like to say I'm almost echoing the last two speakers. I am not a member of whole Washington, but I was at that meeting of the commission last month and saw their presentation, and it was very, very well done. And I was really appreciative of the commission for giving whole Washington a whole hour to talk about their bill, the Washington Health Trust. And I affiliate with Healthcare as a Human Right Washington, but my comments are always my own. But I have talked to a number of people who saw that presentation as well, and uniformly we were impressed with it. And an idea came up that would it be possible for the commission and FTAC, you as well, I hope all you members see the presentation, to maybe use the Washington Health Trust, which is it's the result of many years of planning and work, as a draft model for how we can get to universal and single payer, which we have to remember is what the law calls for, that established the commission. And it's this would be a starting point. So I'm glad to be able to make that comment to you all, and I do thank you for your hard work.
Thank you, Maureen. Okay, opening it up one last time. If there are any hands raised, anyone would like to come off and provide public comments, now is the time. Give it just another minute. Okay. Looks good. Okay, Pam, back to you.
Thanks, Angela. Thanks for driving too. So public comments are an important part of our work. So I really want to thank people for taking the time to respond to us today. I want to welcome back Liz Argent from HMA, who's going to briefly share where we are with our plan and where we're headed next. You can find the work plan under tab 4. Liz, we'll turn it over to you.
Thanks so much, Pam. We always like to just make sure that everyone that we start these meetings with a reorientation to where we are in this multi-month process, just so we all know where we were, where we are heading, and where we are today. So right now we're in September 2023, just to remind folks, in case you've lost track of time. But our process is that we are in the, I believe, the 5th meeting of the FTAC this year, and focused on addressing questions around eligibility for designing the universal system. We have provided some guidance already to the commission on Medicare, which was well received. And now we are trying to do the same with regards to ERISA sponsored plans, looking for a way to provide them some information about how they might consider addressing these plans as they consider design, and exploring the options that might be available or that they might want to consider in moving forward. After today in September, we'll have a conversation. Pam will be bringing this information back to the commission. They may have additional questions, but they may not. And then next time when we come back together in November, the plan is to begin having the same conversations with regard to Medicaid. So that is where we're at today and where we're hoping to get through what we're hoping to get through the rest of the year. Pam?
Okay. All right, thank you, Liz. I find it really helpful to kind of look at the map every time we meet. As Liz noted, this meeting is going to be focused on surfacing options to integrate ERISA into Washington's universal healthcare system, and to start, developing recommendations and advice for the Universal Healthcare Commission. To help us set context for this discussion, we're going to have a presentation from Bill Kramer on potential employer purchaser perspectives on state-based universal healthcare. Members can turn to tab 5 of the meeting materials for Bill's presentation. We're really pleased to have Bill with us today. He's the Senior Advisor for Health Policy at the Purchaser Business Group on Health. Welcome, Bill.
Thanks very much, Pam. And thanks to the Financial Tech Advisory Committee of the Universal Healthcare Commission for this invitation on the chance to talk with you about employers' perspective on universal healthcare plans. I'm going to be covering some more broadly the challenges that are currently faced by large employers, some of the things that large employers are doing to try to address those challenges, talk about large employers' likely concerns with universal healthcare plans, and also, though, what might make the universal healthcare plan appealing or acceptable to large employers. A couple of disclaimers before we start. I'm currently, one of my roles is Senior Advisor to the Purchaser Business Group on Health for health policy. But I'm not speaking today on behalf of PBGH. This is not an issue that PBGH as an organization has tackled or taken a position on. So I'm speaking on my personal behalf. FYI, I'm also a member of the Oregon Health Policy Board. And as you know, Oregon also has a Universal Healthcare Commission initiative underway. But I'm going to be drawing on my experience from not only multiple states policy efforts, but also my previous work as an independent consultant on health policy and my previous experience as a senior executive at Kaiser Permanente, most recently in the Northwest region of Kaiser. But let's dive in here, and I'll try to leave time for questions. Oh, one other disclaimer. We go back. I'll just say I'm not an expert in the legal aspects of ERISA, and I'm not a health economist. I'm in awe of people like Christine Eibner and Erin Fuse-Brown and other experts in this area, and I totally defer to their expertise. But hopefully what I can offer is what large employers think about state-based universal healthcare plans. So next slide, please. So right now, large employers are facing a number of challenges. The biggest challenge kind of that underlies the work on health benefits is that health benefits are a key element of employee recruitment and retention. And particularly in industries where there's a tight labor market, there is a real war for talent. This comes up over and over and over again. Competing to get the best software engineers or the best electrical engineers is a really important aspect of the human resources strategy of these organizations. Of course, one of the challenges too is a high cost of health benefits. As we all know, have been going up much too fast, far exceeding the rate of inflation, which not only is a direct cost, but also indirect costs because it caps how wages can increase and hurts business investment, crowds out other investments. Frustration that employers feel with the lack of transparency, and also I'd say the lack of bargaining power vis-a-vis health plans and provider groups. And on top of this, more recently, employers have been reminded they actually have fiduciary responsibilities as self-insured employers. Similar to the fiduciary responsibilities they have for pension benefits, this is a responsibility to ensure that the dollars are being used wisely. Now, in the past, employers could say, hey, we don't even have the data. They won't give us the data to manage health benefits. Now, with increasing transparency, employers are likely to be held liable if they don't exert appropriate fiduciary responsibility. Next slide, please. So what are employers? This is another just some data from a recent survey by the National Alliance of Healthcare Purchaser Coalitions that very concerned about rising healthcare costs, crowding out salary and wage increases, and really impacting their organization's ability to remain competitive. So this is a serious concern. There have also been similar surveys of CEOs who have serious worries about their ability to afford health benefits if costs continue to increase as they have been. Next slide, please. So what are employers doing? Now, at least the largest ones are accepting or embracing the fiduciary responsibilities, which I will say most large employers have mixed feelings about this. Some are grudgingly accepting this and kind of being dragged into it. Others, though, are embracing this and saying, like, hey, this gives us an opportunity to do stuff we wanted to do for a long time, be more creative, innovative in their benefit design strategies. So these organizations are pursuing more aggressive cost containment strategies, along with strategies to improve access, equity, and quality. Particular areas that I'm aware of that are high priority: behavioral health, serious concern of many large employers, maternal quality and access to maternity services or women's services generally, and a real desire to promote advanced primary care models. It's been a concern that the lack of investment in primary care, lack of development of that important foundation of our healthcare system has been a real worry. So a number of large employers are trying to take more direct action on advanced primary care. And health equity is relatively new, but particularly over the last 3 or 4 years, more large employers are making this a top priority. For more detail, you can see that there's a bar chart on the right-hand side there from that same survey from the National Alliance of Healthcare Purchaser Coalitions. Next slide, please. So what do employers think about universal health care? Now, most of them really haven't worried about it or thought about it a whole lot. But what I've picked up from mostly casual conversations, first of all, they're saying like, well, if we think our benefits are really designed to attract and retain the best employees. And if we lose that differentiation, we got to do other stuff as part of our human resource strategies. So many large employers think like, we got the best program, and that's a key element of recruiting or retaining the best people. If we all go into a universal healthcare system, like, we lose that edge. Now, for multi-state employers, of course, they have concerns about the administrative burden of complying with different state laws. If it's Washington State moves ahead with a universal healthcare system, but Oregon and California don't, or Florida doesn't, and they've got employees in those states, they're obviously would be concerned about that. And it's not just the administrative hassle. They also feel like, gee, we're offering our employees in Washington one thing and our employees in Florida something else. That doesn't seem right. They would prefer not to do that. Another concern they would raise is additional taxes. I know a lot of the financing arrangements or options have been talked about, a payroll tax. So you have to look at that and like, we generally don't like additional taxes. Is it worth it? And kind of an overall sense of this is a loss of control. Now, not that they feel like they have 100% control now, but what few levers they have now to hold down costs, ensure the right package of benefits, particularly customizing the benefits to what they feel are the unique needs of their workforce, they would lose that in moving to something like a universal healthcare system. Next slide, please. You probably already know this, but it's very clear that large employers will fiercely defend the ERISA preemption. Any perceived threat will be jumped on this. One of the organizations I work with quite a bit is the ERISA Industry Committee, ERIC for short. They're very good at what they do. We work with them at PBGH, and I've worked with them in other settings on cost containment strategies, value improvement, quality improvement. But their core mission, as you can read in the small print, this is right from their website, is legal advocacy to protect and uphold the principles of federal ERISA preemption. They've got really good lawyers. They've got really good government relations folks, and they will come out swinging. They have lots of allies among other business organizations, as well as individual employers. So maybe this isn't new news to you, but it's even the hint of a threat to ERISA preemption will be hit with a lawsuit. Next slide, please. One other thing I've found, which I think is relevant to this, there's some research recently was done by some folks at the Employee Benefits Research Institute, published by the Commonwealth Fund, talked about, would you shift your employees to the exchanges? And I think it's some of the same factors would be if you asked employers about shifting to a universal health care plan. I put on the left-hand side the key bullet points and more detail on the right-hand side. But one element is control, as I mentioned before. There's a quote on the right-hand side, which you might be able to read, says, "We like to have control. We can do a better job with design than the exchanges or a universal healthcare plan." Part of that is customizing, and part of that is just doing better in terms of benefit design. A second is a sense of paternalism. You may think this is, you may treat this with some skepticism, since a lot of these are for-profit companies that they do what needs to be done to meet their shareholders' needs. But there are also in many organizations a real sense of, I'll call it responsibility, to maybe a less gender-laden term, a responsibility to do the right thing for their employees. It's good business, but it goes beyond that. To do the right things, to make sure they have the right health benefits, that people aren't financially or physically hurt because of the lack of good health benefits. The last one is, I'll call it, it's kind of risk aversion. Nobody wants to be first. That a lot of large employers, they will follow the herd, but they don't like to be the first ones to step out and do something different. Occasionally you'll see that, but it's pretty rare. So that's another reason why I think it would be, most large employers would be cautious about embracing involvement in a universal health care plan. Next slide, please. So looking to the half full part of the cup, what might make a universal health care plan, state-based plan, appealing or at least acceptable to large employers. One is that the employers would still have the choice to continue to offer their own health benefits or have their employees join the universal health care plan. And that's not just to avoid the ERISA preemption problem, but also I think they would give them more of a sense of control. If they felt like everybody was being herded into a universal health care plan, even apart from the ERISA issues, that loss of control would be something they would resist. Of course, they would look at the universal healthcare product features, particularly the provider network. That's really important to employers. One of the first things a health plan will do in trying to enroll an employer in its as a customer is to do a zip code match of employers and the provider network to make sure that, employees in the provider network. And so there needs to be a good provider network. And I would say that probably what would be most desirable is a choice of plans, because there are many employees who want a broad choice of providers. There's a segment of the consumers that really wants that. But they may want to also, might be good to offer a second option, which is a more of a narrow network plan that is probably going to be less expensive than a broad choice plan. Now, I know there's issues about design in terms of provider payment and so on, but having an adequate provider network, a fairly broad choice, one way or another, would be important. And then, of course, benefits, price, and as I mentioned, choice of plans. Third element, obviously, is better cost control. If this thing doesn't cost less than what they're currently paying, there wouldn't be much reason for them to embrace it. They would be attracted by administrative simplicity. If there's some way to make it easier for employers to manage this, the better. Over the last 10, 20 years, many employers, the resources they have to manage their health benefits have been whittled away. So a lot of the health benefits teams within even very large corporations, pretty thin. And while they have some good people, they don't have a lot of people. And to manage the administrative complexity of their existing plans is a big hassle. So if there's a way to streamline that in some way, reduce the administrative burden of managing multiple plans and renegotiating, contracts every year, and looking at all the different vendors, managing all the different benefit options, that would really be a plus. So hopefully those are the kinds of things that, from what I've seen, you've already been considering as you come up with a design for the universal healthcare plan in Washington State. I think that's it for my presentation. Happy to answer any questions or offer opinions on issues that are important to you.
David, looks like you have a question.
Yes, thanks, Pam. Bill, thanks for your presentation. There are a lot of thoughts in there that were helpful for me to hear, and it's great to hear your perspective. I'm imagining some of these companies have international footprints and operate in countries where there are national healthcare systems. Do you have any perspective on how the company's concerns play out in other countries?
Yes, I would say I don't have a lot of detailed information. A lot of them just, I would say they think the other countries' systems are much better. And particularly the simplicity of most other countries' systems, and of course the lower costs. But they kind of accept the American system as fragmented and complex as it is, and I think would be skeptical that we could move to something that is like one of the international models, at least in the near term. So I would say there are mixed feelings about that. A little story. My son recently started working for a small startup company. It's based in Germany, but he's the head of American operations. And as he's setting up health benefits for the employees that are based in the United States, the people in Germany said, "What? How can that possibly be that it's that expensive, and that you can't offer the same plan to all the employees in one state, and you have to do, it's all this complexity." And he said, "That's just how it is. I can't do anything about it. And that's just, if you're going to run American operations, you got to do it that way." So they roll their eyes and they accept it. But it's, I think they just kind of live with that, those differences, try to do the best they can within the US system.
Got it. Thank you, Bill.
Yeah. Roger.
Bill, thank you again for the excellent presentation. Maybe 3 quick questions. On one of your slides, you listed out a set of interventions that large employers were engaged in. I forgot the slide number around those. And I was, yes, thank you. Do you have any more information, detail about the nature of those interventions that are listed there, or some source where we might garner that?
Well, I would refer you to this National Alliance of Healthcare Purchaser Coalitions survey, because there's a bar chart there, but there's also some text that goes with it that describes those interventions in more detail. Welcome to also look at the Purchaser Business Group on Health website, PBGH. Talks about things, particularly doing what our PBGH members are doing to around accepting the fiduciary responsibilities. I think those are the two best sources I would go to. There's also an upcoming session, a webinar being put on by Georgetown Center for CHRI, Center for Health Research Institute, something like that. Sabrina Corlett and her team on the future of employer-sponsored insurance, and they're going to be probably talking about some of the things that employers are trying to do. So you might check with the Georgetown University CHIR website and tune into that. So that's a quick answer.
Thank you. Then another question on the following slide, if I might, and I'll be brief. Yes. On the first one about loss of differentiated employee benefits. So this is kind of a hypothetical, because I've kind of thought about it as if there was a single payer system nationally or in let's say in the state of Washington, for employers, they could still, seems to me, differentiate among benefits, which I understand is that and wages are a major factor in attracting a strong workforce. They just would, it seems to me, they just wouldn't have to wrestle with the issue of health coverage. I mean, there's a variety of other benefits, if you will, that would falls into that package, and that would be one that seems to me that since everybody would be on a level playing field, they can still have options, if you will, to have that differentiation.
Yeah, that's right. That would make that universal healthcare plan much more attractive if there's an ability to differentiate and to offer richer benefits or different benefits. What they'd be concerned about is a one-size-fits-all benefit package.
This is for a further conversation. Interesting point there. Thank you very much. Thank you.
Yeah, Kai, I can see you have a question.
Thanks, Annabelle. So I had two questions. One is related to this issue of differentiation in employee recruitment as well. I was wondering if you've heard of employers taking a sort of frame shift on this issue of not so much differentiation in benefits and coverage, but differentiation in terms of availability or access, given that coverage does not equal access. So in the sense of like employers offering services that would promote access to the things that are already covered, such as like co-location of primary care services within their area, their workplaces, or access to virtual care and things like that, as a way of achieving differentiation under the same benefit design. That's one question. And then the other one is around plan choice that you talk about later on. Employers wanting plan choice, and that totally makes sense. I was curious if, like, in the hypothetical, if the state had a single benefit design, could you still achieve plan choice by simply allowing employers to have different wraparound benefits that we could add to the richness of those plans?
Yeah, I think I'll answer the second one first. The answer is yes. I think that's if there was a way to kind of wrap around additional benefits that would largely address the concern about differentiation benefits. On the first question about differentiation on access, yes, I would say it varies by employer. I know that some have felt that where their employees are located have poor access, particularly like to primary care. And so they've actually gone ahead and set up worksite clinics or contracted with, done direct contracting, particularly with primary care sites to set up a site, either on site or near site to a work site. And I would say the other general area of access that's a concern besides primary care is maternity care. They're just, we know there are maternity and women's health care deserts in the United States. And so designing, having a provider network or doing things that would enable appropriate access to those services is a key part of many employer strategies. One last thing that's related to this, I think, is telehealth and access to behavioral health services in particular has been a hot button for folks, or the lack of access to behavioral health services, and telehealth being something that can be used to address at least part of that problem. That's been another way that some employers have addressed that access issue.
Thanks. Christine?
Yeah, thank you. So thanks for the presentation, Bill. I thought this was really interesting. I wanted to ask a question about the fiduciary responsibility issue, because I would have said, based on the data that I've seen, that employers are struggling with that aspect of it. And a lot of this is coming from some work that a colleague of mine, Chris Whaley, has done, looking at the price that employers are paying, self-insured employers, relative to Medicare, and has found really that they're paying lots more, like 200, 300% more. There's a lot of variation across states. There's a lot of variation within states, and it suggests that employers aren't always getting the best deal. And one might argue that that would mean that this could be taking a load off their shoulders, like they don't have to worry about this anymore. And I wondered what you thought about that argument, and whether did they have other strategies in mind that they're going to be trying to pursue to like deal with this very, very high price situation, and how the single payer might alleviate some of that pressure.
Yeah, great question, Christine. And shout out to Chris and other colleagues at RAND who've been doing great work on those price differentials. That has been a real driver of employers' concerns. And there's kind of two ways I think that employers are going about it. One is trying to do the best they can as purchasers, either individually or collectively. But they also, most, except for the really, really jumbo employers, really don't have much leverage on that. So that has become an element of the employers' public policy strategies. So the work I've done and my colleagues have done at the federal level and in some states to prohibit certain anti-competitive practices, the kinds of practices that Sutter Health was using to gain market power and raise prices in California, the outcome of that lawsuit, to have greater oversight of mergers and acquisitions. For example, Oregon's cost growth target, healthcare market oversight program, and California's new program for cost and market impact review, and also cost growth target was built on the original Trailblazers in Massachusetts, but California's Office of Healthcare Affordability, Oregon's Cost Growth Target Program, and to a smaller extent, Washington's Healthcare Cost Transparency Board. So it's more in the public policy arena to try to get the market to work better that employers have tried to take on the price differentials, because it's hard as individual employers to exert much bargaining leverage. It's a serious problem. But they're looking for systemic solutions rather than individual solutions.
Yeah. Christine, did you have more? I was going to follow up on your question.
No, thank you. Please go ahead.
I really liked that question. I trying to think how to articulate this, but there's a sense that I've gotten in healthcare over the years. There's a belief that the private sector can do things better than the public sector. So there's a kind of a worry about ceding things to government that the business thinks it has done better or could do better. But this is one area where government leverage and pricing could be, a real help to business. Do you see that there's potential there as we kind of look at these universal solutions to maybe find kind of some commonality of interest to work together on?
Right. I think that most businesses are wary of government price controls.
Yes.
Some really big ones, because they're saying like, well, if they do this to hospitals, they might do it to me as well. And it's almost a philosophical or ideological deep in their guts. It's just like, I'm not sure that's the right direction to go. So the first preference is, but they do see there being really hammered because of the enormous bargaining power of large hospital systems and physician groups and health plans and drug companies, and vis-a-vis the purchase on the purchaser side, and that's led to this escalation of prices, particularly on the commercial side, as the RAND research and others have shown. So their first instinct, though, is like, wow, the market's kind of messed up. What can we do to rebalance it? And so it's less weighted to the supply side rather than the demand side. So some of those public policy things like prohibiting any competitive practices and stronger oversight of mergers and acquisitions to ensure that they're being done in the public benefit, affordability, quality, access, and so on, are the first things they want to do. But they're also recognizing that in some cases the market is irreparably broken or doesn't exist at all. So surprise billing was kind of our first way we were able to cross that bridge for the first time. It's like, yeah, there's no competitive market when a patient goes into an emergency room and and they were unconscious and find out afterwards that the anesthesiologist was not in network and is charging outrageous prices. So like, yeah, that's bad. There's no competition there. So large employers did support surprise billing legislation that passed several years ago. Of course, been fighting these lawsuits that providers and the private equity firms have been launching against it. But also the drug price negotiation. While the employers didn't have to take a position on Medicare price negotiation, they really fought for having whatever Medicare did should apply to the commercial sector as well. Now, inside baseball, that got knocked out at the 11th hour by the Senate parliamentarian. But what that indicated was that employers recognize, like, when there's a monopoly, patent exclusivity, that's not competition. That's not a market. You can't rely on the market to fix that. And so in those cases, it's appropriate for government to step in and set caps on prices or inflation, which is another element of that bill. So it's basically where the markets don't exist or have failed irreparably. I think employers are accepting this idea of government price controls. They're also embracing, I'll call soft controls like cost growth targets, like the Massachusetts Health Policy Commission, Oregon's cost growth target program, and California's Office of Healthcare Affordability. I call that soft price control because it's not you all understand. So I'd say that the employers are moving in the direction of recognizing that government needs to step in, not just to fix the market, but in some cases to exert its either direct purchasing power or control over prices in the commercial market. Still have a ways to go on that for having it apply broadly, but they're seeing how the market does work in many cases. Long, complicated answer there, Pam. I hope that addresses what you were asking.
Yeah, it did. It was a complicated question. So that Christine, launched us in that direction. Any other questions for Bill? Okay, Bill, thank you so much. This has been a really interesting discussion. Really got the juices flowing. So thank you for your time.
Great. Thanks for the opportunity to join you today.
Thanks. I think next we're going to hear from Aaron Fuse-Brown, who will share ERISA considerations for Washington. Aaron's presentation is under tab 6 in your materials. And there will be points during Aaron's presentation where committee members will be invited to ask questions. Aaron is the preeminent expert on ERISA, and we're lucky to have her as our guest today. Aaron's the director of the Center for Law, Health, and Society at Georgia State University College of Law. And thank you for being with us today, and welcome, Aaron.
Great, thanks for having me, and I appreciate the opportunity to talk with this group. I will try to be a little quicker in my presentation, but if there are hands that I'm missing, someone just sort of interrupt me and stop, and I can answer questions along the way. So I am a lawyer. I am not your lawyer, and this is not legal advice. I have to give that caveat. And I also have to acknowledge my research collaborators on these topics, including Elizabeth McCuskey at Boston University, Jamie King at University of Auckland, and Katie Gudikson at UC Law San Francisco. All right, next slide. So based on my earlier conversations with in planning for this meeting, this is sort of the agenda that I'm going to try to get through today. We're going to do just a bit of a refresher on the Affordable Care Act's requirements for employers, and then we're going to talk about the lack of an ERISA waiver in the statute, and then really get into some options to include employers in a state universal health care system, and also some ERISA implications and trade-offs. All right, so next slide. So in the big picture, in the Affordable Care Act, the policymakers, the drafters of the Affordable Care Act really wanted to keep employer-based coverage intact and encourage employers to continue offering coverage to employees. And so as a result, we have the Affordable Care Act's provisions for minimum essential coverage for large employers, which are colloquially called the employer mandate. These provisions have two sort of components. One is a penalty for businesses that are considered large, over 50 employees, that fail to provide any minimum essential coverage that is considered affordable and satisfies the minimum value standards set under the statute for their employees. And so there's a penalty if the employer simply doesn't provide that type of coverage. There's also a penalty for large employers for every employee who ends up going instead of taking their employer's offer of coverage to the Affordable Care Act marketplace and gets a subsidy to buy coverage there if the employer coverage wouldn't have been affordable or meet the minimum value for that employee. So there's a per employee penalty, and then there's just a larger penalty if an employer drops coverage altogether. Of course, affordability is measured on a sliding scale based on a percentage of the individual's income, and it ranges from about 2% for those on the lower end of the poverty scale, between 100 and 133% of the FPL, and up to about 10%. This is like the premium costs for the employee for those making closer to 400% FPL. So the minimum value requirement, think of this as sort of like actuarial value. This is met if the plan covers at least 60% of the total costs incurred under the plan. So it's not that high of a bar, but that is the minimum value. And the employer mandate, one thing to note is that it is subject to the Affordable Care Act's 1332 waiver provision. So it can be potentially waived by the federal government if the state asks for it. All right, next slide. All right, so I'm not going to do an explainer. I think this group is pretty well versed on ERISA, but just to refresh your recollection for the purposes of this conversation, ERISA preempts any and all state laws that relate to an employee benefit plan. And while fully insured plans are regulated by state insurance laws, self-funded employer plans, which is about 60% of people with employer-based coverage, or a third of the entire non-elderly US population, cannot be regulated directly by state insurance regulation because they're self-funded. And so they're completely preempted any state attempt at regulating. All right, next slide. So there was a bit of a question about whether or not, similar to the Medicare process, maybe the Medicaid or the Affordable Care Act process, whether there is a waiver that can be sought from the federal government for ERISA preemption. And the answer is there is no such waiver that exists under federal law. A waiver is a provision of statute that allows the federal government to administratively waive certain federal legal requirements when a state regulatory scheme basically applies and asks for that waiver. But there, of course, is no waiver under ERISA. And so unlike all other aspects of federal health law, such as the Affordable Care Act, Medicaid, and Medicare, the federal government cannot waive the requirements of ERISA or ERISA preemption for a given regulatory scheme. They simply lack the authority to do so. So the Department of Labor, which administers ERISA, is not even the final arbiter of whether or not a state law is preempted by ERISA. That is decided entirely by federal courts. The federal courts independently make this determination in response to those litigation challenges usually brought by industry. So there have been several cases where the federal court has basically disregarded the expressed views of the United States Solicitor General or the Department of Labor, amicus briefs arguing that a particular state law should not be preempted, and basically just say, thanks for your input, United States government. We're going to go the other way and we're going to decide that it is, or it's, it's not. So basically the Department of Labor and the United States federal government's views on whether or not a state law should or should not be preempted is definitely not binding on federal courts, and is sometimes not even persuasive. So short of asking Congress to alter this and add a waiver to the ERISA statute, there is no possibility of asking for a waiver of ERISA preemption. All right, so moving on. So I understand that the focus of today's discussion is on mechanisms for the state universal healthcare planning process to capture some amount of employer health expenditures. And why is this necessary? The reason this is a necessary conversation is because without capturing the employer-based market, the plan is neither universal nor fiscally sustainable. So it is not an option to plan a universal healthcare plan that doesn't include the large group market, right? It's just not a universal plan. You see from the pie chart, this is Washington's breakdown. Employer-based coverage covers 52% of the population. Employer-based coverage accounts for about half of the population nationally and roughly 20% of national healthcare expenditures. So why only 20% if it covers half the population? And this is because the population is healthier on average than the rest of the population. And so frankly, states need to capture this population to have an acceptable risk pool, right? The risk pool for the state plan, whatever that universal plan might be, will be completely skewed if it excludes the employer-based market. And whenever you're dealing with the employer-based health plans and that market, of course, that implicates ERISA. So we need to figure out how you would go about designing a universal healthcare plan that both includes employer-based coverage without running afoul of ERISA. So I wanted to acknowledge that this is by no means the only or most important policy goal of a universal healthcare system. I've listed other potential overarching policy goals that may be on your mind as you design your system. Of course, this is not an exhaustive list, but I just want to point out that including employer-based plans is sort of a necessary component to all of these goals, particularly the first and second ones, right? It's again, not universal if you don't include this population. It's not fiscally sustainable if you don't include this population. And, again, as we heard in the last presentation, that large groups also are interested in improving affordability, accessibility, equity, and administrative simplification. All right, so the next slide, please. So there is a spectrum of policy design options for designing a universal healthcare system at the state level. So this, of course, requires defining what you mean by universal. Do you mean universal eligibility, universal enrollment? Does the enrollment all have to be in the same plan? Do you hope to replace the multi-payer system with a single state administered plan that covers everyone? Or is the committee, or is the plan, basically the policy goal, to slowly or not really replace the multi-payer system, but offer a comprehensive, affordable option that is available and increasingly accessible to everyone in the state? And do you hope to get there all at once? Do you plan to move down a glide path? And sort of those trade-offs will help you kind of figure out where your design options might stand. So the spectrum starts where you are on this slide. I'll call that the limited public option. And in some ways, Washington is already ahead of many or most states because you already have the Cascade Select, what I call a limited public option to build upon. So the next option, potentially along the spectrum, if you were to think of this in a linear fashion, would be the comprehensive public option that may call for a government-sponsored or more heavily regulated state public option plan. But more importantly, what differentiates a comprehensive public option from a limited public option is the broad availability to any resident in the state, including those who have employer-based coverage. The furthest option along the spectrum is a state-based single payer plan. And here the government would administer a plan that provides the same coverage to all residents in the state and largely would eradicate and replace the multi-payer system that we have now. All right, so next slide. So along this same spectrum, each model entails a different balancing of policy goals with legal trade-offs and other trade-offs. So for the limited public option, what you already have with Cascade Select, the goals really are to plug holes in the individual market and inject some downward cost pressure in that market. It obviously has limited reach, right? It only reaches those the marketplace plans. And it focuses on the marketplace and largely leaves intact the multi-payer status quo. There are no ERISA implications here because it doesn't even touch the large group employer market. When you move down the spectrum toward the comprehensive public option, you could build on a limited public option by making it universally available to all residents in the state. It would still simply be an option, again, not a required switch, but it would start to break the link potentially between employment and coverage for some people, where individuals or employers could choose the public option instead of their current job-based plan. So depending on how it's designed, it could form either a glide path to single payer, or it could be the steady state end state of the design. It is possible to design a comprehensive public option without too much ERISA preemption risk, and I'll get into the details on the next minute or so, but you still need all the other waivers, Medicare, Medicaid, ACA waivers, to bring in all the other payers and make sure that, especially if it's going to be offered on the marketplace as its primary place where it is administered. And then finally, there's single payer, that this would entail universal enrollment of all residents. Total market reach is the goal. And with that, complete administrative simplification, so providers do not have to contract with dozens of payers and manage so many different payment rates. The trade-off, of course, is political difficulty, right? And what role would remain for the insurance carriers in your state? How do you get the providers on board? And of course, it's more legally difficult under ERISA, and it would require successful negotiation of all the other waivers to fall into place as well. Of course, it's not impossible. I've written a whole paper on ways it can be done, and I'll talk about that again in a few minutes. All right, so next slide. So I said there are a few legal difficulties with ERISA in designing a comprehensive public option. That's the middle option on the last slide. That doesn't mean there are none. The first thing that a state cannot do is it cannot mandate that employers offer the public option to employees. That would be preempted by ERISA. However, if it is structured as a voluntary option for employers or employees, then it retains a meaningful set of plan choices for the employers and the employees, and it would avoid ERISA preemption under the current Ninth Circuit precedent in the Golden Gate and City of Seattle cases. And of course, Washington is in the Ninth Circuit, so this is precedent that you can feel more comfortable applies in Washington. Employers could continue to offer their own plan, the public option plan, or both, right? It could be employees could choose. The funding mechanism of a comprehensive public option plan, of course, we don't have any models across states. We have bills, but no models of enacted comprehensive public options. These funding models that we've looked at in the bills that we've surveyed include payroll taxes, it includes premiums, there are income taxes, there are different ways to pay for it. Both can be structured to avoid ERISA preemption. So payroll taxes are levied on wages, they're not levied on benefits, so they don't on their face relate to or make any reference to an employee benefit plan. The second thing is, of course, employers may be one way to increase the sort of durability against an ERISA challenge would be to allow employers to be exempt from the payroll tax if they offer coverage that is at least as affordable and comprehensive as a state public option plan. That is the classic pay-or-play dynamic upheld in the Golden Gate case. Individual premiums do not implicate ERISA at all, as long as the state doesn't require the employer to participate in the contribution of premiums or the collection of them. An employer could do so voluntarily, but it cannot be required by the state. If the employee chooses the public option, they could pay a premium as they do now on the marketplace. Note, employers may want to offer employees premium vouchers to purchase a public option plan as part of an employee benefit package. And then there's nothing to stop them from doing so voluntarily. The state would need a waiver, however, of the Affordable Care Act's employer mandate, so that this could count as offering minimum essential coverage if the individual still somehow receives a premium tax credit to buy the public option plan on the marketplace. So it implicates that first slide of the ACA's employer mandate. Of course, there are trade-offs. A payroll tax, if you wanted it to have no exceptions for employers who offer similar comprehensive coverage, would accelerate a market shift to the state plan, right? If you don't give employers an exceptions, they're not going to double pay in many cases, but it does increase the ERISA difficulty. It's more like the single payer analysis where, maybe it does get to be exorbitant for an employer to both pay a payroll tax and continue to pay for employee benefits. The individual premium only model is another potential model that I've seen developed in state bills. It doesn't capture, however, the employer's share of premium spending currently, and it may not therefore raise sufficient funds to finance the plan. There are also tax implications. That's beyond the scope of this presentation, but I just wanted to flag that these do raise some tax implications. All right, next slide. All right, so now we're switching to the sort of state-based single payer end of the continuum. So as you're probably catching on, a state employer mandate to participate in a single payer plan would be preempted by ERISA. So states have to come up with alternative mechanisms to accomplish indirectly what they cannot do directly because of ERISA preemption. So states' bills have developed three primary mechanisms to navigate around these limitations and capture employer expenditures by both pulling the funds and the covered lives using a combination of carrots and sticks into the state-based plan. The first sort of mechanism we call a funding plan, type A. A funding plan is a combination of payroll and income taxes, and it does most of the work of capturing employer expenditures, individual spending, so basically taking what we currently spend through the employer-based benefit spending right now and moves it into a state-based single payer. It also provides incentives for both employers and employees to make a choice and switch voluntarily to the state-based plan because they don't want to double pay. A payroll tax that everyone must pay can be analogized to a property tax to pay for your public schools, right? If you want to double pay and also pay tuition to go send your child to private school, you are free to do so, but that doesn't relieve you of the obligation of paying your property taxes. So that's sort of the analogy here. It does raise the question of when and whether that would cross the line of exorbitance in the mind of some court in terms of triggering ERISA preemption. And we just don't know where that line is. It's a concept, it's not a number. And so we don't have really a firm sense of where courts would land on that question. On the second feature, we call this the provider restriction. A provider restriction is a mechanism that basically is a provision in these bills that tells healthcare providers that if they participate in the single payer plan, they can only bill the single payer at single payer rates. They can't bill the patient, and they can't directly bill other payers. A provider restriction would create additional incentives for employees to drop their employer plans because it would potentially shrink the participating provider network for the employer-based plan. If providers are saying, if I'm sort of using the single payer plan as sort of my billing agent, I'm going to opt for that administrative simplification, and I'm just going to stick with that. So the provider restriction is a way, not necessarily of eliminating provider participation in employer-based plans, but making it, again, administratively simpler for providers who may want to switch to just serving the single payer population. Remember, everyone in a single payer state is automatically enrolled in the single payer plan. So someone may have double coverage, but no one would have no coverage. And finally, the third mechanism is an assignment, subrogation, secondary payer, what we call the pay and recoup provisions. These enable employers who wish to continue to provide benefits to do so, and allows the single payer plan to capture some of that spending. If a patient has dual coverage, then the single payer plan can pay the provider for the services and then turn around and seek reimbursement as a secondary payer provision from that collateral source of coverage, such as employer-based plan. All right, so next slide. So here's some of the ERISA analysis. In terms of drafting an ERISA-resistant universal plan, hold on, actually go back to the prior slide. All right, I'm going to do the ERISA analysis now on the single payer plan. So let's keep it here for now. There are strong legal arguments why all of these three provisions to capture employer health spending should survive ERISA preemption. Again, this is just my opinion. It's not been tested in court, and as we heard in the last presentation, a state can pretty much guarantee it will get challenged in court. It's not a matter of if, but when. The first one, and probably the most important, is that payroll tax funding mechanism. And here, as I mentioned before, states do have a very wide latitude to levy taxes. That is part of a state's, sort of sovereign power. The payroll tax that we saw in a lot of these bills are calculated as a percentage of wages, again, so they don't directly reference or rely on the existence of an employer benefit plan, nor do they require employers to alter their employee benefit plans. They merely potentially encourage a shift to the state's health plan, because with a payroll tax, an employer could continue to offer its coverage, but employees might choose to say, well, I'm not going to both pay for my employer-based coverage if I'm already paying for in payroll taxes and automatically enrolled in the state-based plan. If the state-based plan, again, has a comprehensive provider network and good benefits, that might actually just attract most of the employees to move in that direction. Nevertheless, of course, courts could interpret a payroll tax as essentially forcing an employer to change its employee benefit plan by creating such a strong financial incentive that it rises to the level of coercion, so that the employer feels forced to drop its plan and cover its employees through a state single payer plan if that was in existence in that state. And the payer play cases, the Golden Gate case in particular, does sort of allude to the level of sort of how much does an employer feel that it has a reasonable alternative among either keeping its plan or having a plausible alternative for its employees. And the fact that there is a plausible alternative in the state-based single payer does strengthen the case. Of course, there is some uncertainty there. Generally, for the provider restriction, ERISA does not preempt state regulation of healthcare providers. That has only an indirect effect on employee health benefit plans. And so the question is whether there is, again, such an indirect effect that it would cross the line toward coercion. And the way it might do that is if the provider network regulation had the effect of essentially eviscerating the provider networks for employer-based plans overnight. But if it just sort of nudged providers to sort of choose who they want to be, or in favor of administrative simplification, obviously every patient would still be available. Every provider could still see their patients, but the question is whether they would continue to participate in provider networks of employer-based plans. However, allowing providers to contract with other plans is an alternative to make provider enrollment, again, voluntary, and it would lessen the risk of ERISA preemption. But a lot of times patients follow their providers, right? They follow their doctors in particular. So you have to think very carefully about what you do with those providers, because where the provider goes is where the patients go. And so one alternative would be make participation in the single payer plan sort of auto eligibility for providers, but they don't have to enroll in the state single payer plan right away. But if they do, they have to do so exclusively. So that's one alternative that we saw some states toy with, and others would be to say all providers are just automatically enrolled, but they are not barred from participating in other provider networks, but they still have to, from the billing and collection standpoint, have to go through the single payer plan. So those are some alternatives there. I think those, again, don't generally rise to the level of such a coercive effect that it would overnight, eviscerate the provider networks of employer-based plans. And then finally, on assignment and subrogation, or those pay and recoup provisions, the combination of an assignment and subrogation provision with the provider restriction, those two in combination, may actually help strengthen the sort of ERISA preemption case for the state, because it gives the employer plan a plausible way to continue to exist, right? The provider can't directly bill the employer plan. The single payer plan will pay for the care, right? Turn around, seek reimbursement from the employer-based plan if the employee happened to have dual coverage. But it would be contemplated that there would be some residents and employees who would continue to have dual coverage for services. All right, so that's the sort of ERISA analysis of the single payer option. The next slide is just sort of a strategy about what does it take to draft an ERISA resistant or compliant universal healthcare plan. The first option may be simply to aim for a comprehensive public option, whether or not the state plans to use it as a glide path towards single payer, right? Because it doesn't pose as much of a ERISA challenge. It does explicitly contemplate that employer-based coverage would continue to exist to some, fairly robust degree in the state. The state could structure the financing mechanisms, pay or play payroll taxes, premiums, marketplace subsidies to avoid ERISA preemption, because an option by definition preserves employers' choices and does not force the employer to choose a certain form of coverage, which are significant questions for an ERISA preemption analysis. The second option would be to aim for a single payer, but acknowledge that there's not a way to overnight eradicate an employer-based coverage through the state's legal command, right? That is not allowed under ERISA. And so instead, the state has to create a series of carrots and sticks to move the market there incrementally, however, slowly or quickly, but to nudge the market in that direction and allow individuals and employers to sort of slowly make their choices and create incentives for them to make that choice on their own. So a belt and suspenders approach in terms of design would be to kind of include a little bit of all of this stuff, right? To include a funding plan, you need that for financial sustainability anyway. There are different analyses that involve payroll taxes, income taxes, premiums, or some combination thereof. Obviously, that has political and financial ramifications. But also think very carefully about provider provisions, because that network really is going to be key in terms of building participation, as you know well from your experience with Cascade Select, and to also include a pay and recoup mechanism, right? Something that allows the state to really kind of start to serve as that administrative simplification and to really be able to see the services, provide prompt payment, but then have to turn around and seek reimbursement if someone turned out to have dual coverage. And then finally, you'd always want to include a severability clause in case any one of these provisions was determined to be preempted by ERISA. You wouldn't want the entire structure to come crumbling down. You would want it to be severable from the rest of the act. All right, next slide, and then I think I'm almost finished. So this slide is sort of non-duplication. What do I mean by that? This wasn't actually part of the prior requests of this committee, but I saw it in nearly every state single payer bill that I reviewed in my research. A non-duplication provision basically bars anyone from offering coverage that duplicates the state plan's coverage. Think of it as the inverse of a mandate to use the state plan. You're prohibited from offering any alternative duplicate coverage that basically would cover the same benefits as the state plan. So this tells you that states cannot impose a non-duplication provision, particularly on self-funded employers, because of ERISA. Right? It's just the inverse of a mandate. So they could prohibit state-regulated insurance carriers from offering duplicative coverage without running afoul of ERISA, but this doesn't get at most of the private employer-based market. This means in reality that even the strongest forms of state single payer will not eradicate the employer-based coverage in that state. That's just the reality. And this underscores why the nudges and financing and provider network provisions and pay and recoup provisions are really necessary to push and pull both covered lives and dollars into whatever the universal plan would be. But states could consider allowing complementary supplemental wraparound coverage that we heard talked about in the last presentation to be offered to cover costs and services that may not be covered by the state plan. This could preserve a role for insurance carriers and allow employers to use benefit design to differentiate themselves to attract and retain employees, as we heard is a concern of employers. This undermines the equity goal a bit, right? I mean, that there's a direct trade-off there. It's likely the wealthy and the powerful, we know, who are going to have access to supplemental coverage. But it is something that we see in, say, the Medicare program, right? We all are familiar with Medigap coverage. So it is something that is not necessarily anathema to single payer or universal health systems, but it has to be designed carefully to keep in mind equity considerations. Okay, now last slide. So universal health care is not achievable without capturing the employer market. So this is a nut that the state would need to crack. This, of course, implicates ERISA. There are ways to design a universal plan that avoids ERISA preemption, and the two main models would be a comprehensive public option. And if it stays meaningfully optional, then it is likely to avoid ERISA preemption issues. And a state single payer plan can be crafted. It's more difficult, but it can be crafted, again, to survive an ERISA challenge. And the policy design, of course, is driven by your own state's goals and the legal, financial, and political constraints that you face in the state. All right, so I'm going to stop there. There may be questions, and I know you have other things on your agenda. So thank you.
Thank you, Erin. We have a question from Christine.
Hi, yeah, thank you, Erin, for this presentation. I wondered if you could comment on the provider restriction approach. And, it makes sense, as you explained it, that this may not be subject to an ERISA preemption, but I'm wondering if there are other legal challenges that the state would have to worry about in implementing that specific thing, which would seem to preclude the provider from entering into a contract with the, self-funded plan that was willing to pay up more than the state negotiated rate, and whether that could pose other legal challenges that the state would have to be concerned about.
Yeah, I think that, as we see with any provider rate regulation is something that states have the power to do today. They may not have the political will to do it, but they certainly could just tell providers, as we see in Maryland and as we saw historically in other states, this is how much this service is going to be reimbursed in this state, period, right? And so a provider restriction that caps rates at a certain level, at the single payer plan rate, for example, would not necessarily on its face challenges in terms of, I can imagine challenges like this is an unconstitutional taking without just compensation, but we have a fairly strong track record of states in particular having the ability to regulate rates and cap them even and tell providers what they can and can't expect to be charged. On the contract provisions, I think you're right that there may be some discomfort about not allowing providers to enter contracts with certain entities, but I think it could be framed as a condition. So if you want to play ball with the state single payer plan, then you can, but you have to be an exclusive provider for us. And then it's sort of again, we're not telling you can't contract with someone else if that's what you want to do, you just can't also participate in the single payer plan.
Thank you.
Are there other questions? David.
Yeah, Erin, thanks for being here with us. I was impressed with the article that you and Elizabeth had written. The impression that I came away after reviewing that article was that every potential path leads to legal action, and it felt more pessimistic than the impression I'm getting from your presentation here today. And I'm wondering, did I misread one or the other, or have you become more optimistic over the last couple of years?
No, and I think that I would say that I think that both the article and this presentation are consistent in that we think that legal challenge is inevitable, right? That isn't something that one can avoid. One can't design something that touches on the employer-based market, even if you think you'll win, and not expect a legal challenge. So there has to be a strategy in place to defend it, because so that's inevitable. Whether you win is a different question. And so what I think we laid out in the article was, how do you craft such a single payer plan to both, capture the employer-based market, which is the policy goal, and also have the maximum chances of winning a preemption challenge from industry, because that is going to come. So I think in that regard, I don't think that I'm necessarily more, sanguine about it than I was in the paper, but I think that there are some uncertainties. I think, again, where that line of exorbitance is like anyone's guess. And so that's a big risk. But there are other things that one could do, I think, that would place a state in pretty strong and firm footing vis-a-vis, ERISA preemption, to be able to kind of move the state towards something that looked like a universal plan, or at least something close to a universal plan, where employers would voluntarily, with some incentives and nudging, decide to move in that direction as well.
Got it. Thank you.
Yeah, Roger?
Thank you. And let me say again also, thank you for this wonderful presentation, and having the pleasure also of reading you and your colleagues' articles on ERISA have been very, very helpful. And I know for our group's thinking, and certainly my own thinking. So thank you again for that. I have three sort of maybe questions and comments. One is a bit of an editorial one that Pam will let me tolerate. In one of your slides, I think it was on slide 7, you laid out a spectrum of options towards a universal healthcare system. And I would, this is my editorial, I would kind of like to add to that, between what I would call the limited public option and the comprehensive public option, is this notion of the state itself consolidating all of its purchasing, that which it today has a scope around, as a step towards a single payer or a comprehensive public option. For example, in our state's purchasing through its various programs constitute about 1/3 of all persons who are insured today. So I guess I see that as along this continuum, as another, if you will, step in building that platform. My editorial comment. The second question I have is in the area of payer play. And let me see if I can say this clearly. In my own mind, I put payroll taxes. I'm thinking the model that Oregon is developing now as an example that I know you're familiar with, in a different bucket, if you will, than how I have interpreted payer play. And here's kind of my problem, I think, of payer play. One is to say, well, if you meet our expectations, the benefit design, comprehensive X, Y, and Z, you're playing. So therefore you have a safe harbor. If you don't, you have to pay. And it seems to me in that arena, that could be subjected to a degree of ERISA challenges, because it's sort of a coercion of saying, you're telling us how we have to define our benefit in order to avoid, if you will, the payment is otherwise associated with that. So I guess what I'm trying to say is that when I see that in its way, certainly kind of a what I'm looking for here, potentially leading itself to ERISA challenges, because of that dictation of you have to do this in order to not have to make a payment to us. I guess that kind of falls in an area of coercion. And then the last, maybe I could comment on that, and then my last one, I'll get off here. You've been extraordinarily helpful, both ourselves and to Oregon, and I would hope as we further our thinking, both our FTAC and our Universal Healthcare Commission, and we more develop our thinking, that we might call upon you in the future to provide some paid or unpaid consultation to us in helping us along that pathway. Well, so I guess my question leading forward would be the one on comments on payer play.
Yeah, so I think, you're right. It's not totally on all fours with the payer play design in San Francisco or in city of Seattle, in either of those cases. But I think that the concept is similar in the sense that I think that there is a way to say, look, employers are given a choice. They can either continue to provide their benefits, and if it meets these standards, which is what you say is new, and I agree with that, that is new, then you can be exempt from this payroll tax or from paying into the state plan. If you would rather just pay into the state plan and drop your benefits, that's an option. So you now have two options: offer comprehensive coverage and then or pay. And then there's a third option, and that is, let's say your comprehensive coverage or your coverage isn't quite comprehensive enough, which I think most large employers would say that they already exceed a lot of the comprehensiveness standard there, that they serve as the benchmark for what comprehensive essential health benefits are without being forced to do so by law. But if they for some reason said no, we don't want to change our benefit design, then I think what you're saying, then you would have the option of keeping your current benefit design and paying the payroll tax. And again, then it just puts you in that question of, is that double payment inherently coercive? And I think it just depends, right? I think it depends on how much an employer feels forced, or how much it actually has enough wiggle room there to make choices among meaningful options and alternatives. And I think that's all that the Ninth Circuit required in the Golden Gate case, was that there be a meaningful alternative in addition to offering one's own coverage.
Okay, thank you, Erin. I'm going to go to Christine really quickly, because we need to move on to our discussion to make decisions, start doing our advice. But I'd like, Christine, we can be a little bit fast.
I can keep it quick. So I just want to understand. So if the employer just imposed a payroll tax without any condition, like you're getting a tax, we're going to fund an employer, we're going to fund a single payer plan, and there was no pay or play, it seems paradoxically that might make it less risky from a risk standpoint. And I just want to see if you concur with that, because what's the difference between doing that versus like funding environmental cleanup or paving more streets or something like that? Whereas the pay or play seems to introduce potentially a coercive argument. And
right, because it connects it to the employee benefit in a way that a payroll tax does not, right? The payroll tax doesn't have anything to say about whether you continue to offer an employee benefit plan.
Yeah, so you would agree it might be just simpler just to do it. Okay, I see.
Maybe, okay. Yeah.
Thank you. Erin, thank you so much for the presentation. That was amazing. I'm going to ask Liz to join into the conversation now to help set up how we can go through kind of our decision-making framework that we need to do here. And I think we only have Erin for about 10 or 12 more minutes. So I want to make sure we take advantage of her expertise while she can remain with us.
Great. And I'm going to have Gary Cohen, my colleague, join us. So at this point, what we're trying to do is we're going to go through, similar to what we did with Medicare, a sort of range of a spectrum of potential options about ways we might want to move forward. And so first is making the decision about whether or not we would want to obtain a federal waiver, and then look at the alternatives if we decide not to do that. So that's what our how we're planning to do this. And so, and what we're hoping for is similar to last time, brief discussion about each of these so that we can capture the discussion points related to each of these and convey it to the commission as you all make your decisions. So, Pam?
Yes, thank you. And I would like to kind of ask the FTAX indulgence to actually take federal waiver almost, I guess maybe I should put it this way. Does anyone want to speak in favor of a federal waiver, since we've been kind of briefed that it's impossible to obtain? And I think Erin, it looks like Erin has something to say.
Yeah, I just wanted to make sure everyone did get the message. There is no such thing as a federal ERISA waiver. Right.
There, I couldn't say it better than that. So I think that if anyone, does anyone want to, hands up, is Roger, do you want to speak in favor of a federal waiver?
No, but given that
then,
topic,
then let's put this one, let's put this aside, and then I'm going to get to you, and then Gary.
No, I was just going to say, I read this to mean ask for an act of Congress. I mean, because there is no federal waiver, but Congress could pass a law that said, sure, states can do what, whatever Congress wanted. You can all think about how likely that is to achieve, but it's.
I feel they're in the same category, and these other things are complex, and I'd like time on those. Okay, I think we're good. So I think that I also, looking at this, number 6, combining 2 or more options. I feel like we need to kind of think about that possibility as we go through everything, because all of these things combine, and it looked as though all the other, I mean, it seemed to me that nearly every universal health effort in every other state combined methodology. So they didn't just do one single thing. So it's something we might want to think about.
And that's the path that the commission, as recommended by the FTAC, took last time. And it was through the discussion that the FTAC had, where it said, we want to do this, but we also want to pursue this at the same time. So this is your discussion.
Right. And things can be combined, or they can be stair-step too. You can decide we'll do this first while we wait for a more complicated effort. So the first one is optional for employers to participate. And I would love to hear committee members' views on that. No comment. Christine.
Sorry, it just seems like this, it feels like if it wasn't optional, then that would cause the ERISA, like a real likelihood of an ERISA challenge and problem. So I wonder if this one is kind of problematic for that reason.
You mean that problematic in the sense that it would have to be optional, at least at first?
Well, yeah, it sounds like, I think ERISA would make it impossible to legally make it mandatory. So yeah, I'd be worried about trying. So it feels like this is not really a choice. Like it has to be optional. Yes.
Yeah, David.
Yeah, Pam, it sort of feels like we need a legal technical advisory committee more than a finance technical advisory to weigh through these. But the impression I get is the same as Christine's based on reading what Aaron had written in the past and hearing the presentation today.
Yeah, that was similar to my thought. Roger, did you have a different point of view?
I just briefly to say I would support this option, particularly as it pertains to the discussions around a comprehensive public option, to make that available to employers, whoever, to be able certainly to volunteer. And that's what I read about, that voluntarily participate in that. So I would, it needs to be ferreted out more, but I would support this option.
Okay.
So you're looking at it from the flip side, Roger, that it's optional, in that we're not requiring, but we're also making it an option for them because it might be a good thing.
That's correct.
Okay.
That's good. All right. Kai or Bob, Ian, any different points of view?
No, I have the same point of view. It's what Christine said. Okay.
All right. The next one is a pay or play or meaningful alternative. This one's a tough one is because it's big. So anyone want to dive in on a point of view? Roger, you have your hand up.
I do. I would like to propose that this option be broken apart, if you will. And by that, I mean that we would separate out among these options, pay or play as one option. Another would be the comprehensive public option. I see these as two different separate options that don't necessarily need to be tied together. So that, for an example, you could have, a comprehensive public option, and you don't need to necessarily have pay or play in it. There are other ways of financing it, for an example. So I guess I would suggest that it be broken into pay or play, maybe it's 3 and 4, whatever would be the comprehensive public option. and I know that folks get tired of this, but I would again offer and these are steps towards trying to get towards the universal healthcare coverage, this notion of consolidated state purchasing as an option along our pathway towards the universal healthcare coverage. In my view, it avoids ERISA challenges. There are waivers today to bring Medicaid into that consolidated state purchasing. So it serves, in my view, as a platform to build these other ones on. And so this would be an opportunity to share that notion with the Universal Healthcare Commission as one strategy in avoiding or addressing ERISA.
Also, I want to, Roger, you're doing a nice job of reminding me that different points of view are going to be conveyed to the Universal Healthcare Commission. We don't have to have 100% consensus. If people feel differently, have different ideas to add, we will convey that to the Universal Health Commission, particularly your thoughts about consolidated purchasing. I'm going to call on Aaron and then Kai.
Thank you. I just wanted to note that I was asked about the possibility of a state, I don't know if this is what you mean by consolidated state purchasing, but in state public employee buy-in option as being the basis of the public option. I separately did an analysis of that possibility. There are a couple bills from a couple years ago from other states that looked at that possibility. And for a variety of reasons, partly ERISA, but not in the preemption sense, but in the losing government exemptions, creating a multi-employer welfare arrangement, OMIWA, state law, and union bargaining that seem like a non-starter. So there are some reasons why it's very attractive conceptually, but it just simply opening up the existing public employee plan as the public option for others to buy into, including other employers, private employers, would create a bunch of other legal problems that may make it unworkable. So I just wanted to flag that.
Okay, duly noted. Thank you. Kai?
Yeah, just to preview my opinion. So I would be in favor for a combination of a few of these, but the one that really stands out as the odd one out seems like number 3 in those combinations, in that pay or play, as we heard from Erin and from her research, that the pay, depending on the size of the pay, is problematic, right? And you can accomplish quite a bit of that through the payroll tax option number 5. So I really motion to not recommend this one.
Thanks. Others on number 3? Just making sure everyone's had a chance to talk. Okay, provider regulation and incentives. Bob.
Well, I think given my experience and also what Aaron had said earlier, and just the basic idea to make any sort of public option or comprehensive public option or universal healthcare initiative affordable, you have to control expending, and prices are the biggest problem in healthcare spending in this country. So I think, yeah, and given the fact there's precedent, legal precedent for states to set rates, this is an absolute requirement. So that if I'm understanding it correctly, that would be my perspective on this.
Mm-hmm. I thought of that as well, as that in the provider regulation that you kind of create a pathway to doing something on costs that also could be very appealing to employers in terms of working together on it.
Yeah, we heard from Bill Kramer earlier. He talked about employers being, hesitant to, unless the market is found to be flawed. And Aaron had written something several years ago about market failure in healthcare. I don't want to steal her thunder, but it is profoundly flawed. And if there's any industry that begs for a regulatory solution and to regulate rates, it's healthcare. Particularly the hospital market, and also I would argue the physician market and probably drugs as well. But So anyway, I just think this is a no-brainer. We've got to do this for affordability purposes. And oh, by the way, every other developed country in the world does this. And I said this before in other meetings, it's no coincidence that their expenditures on healthcare are half ours. It's because they have a regulatory system to control prices and also volumes to a certain extent in some cases. But anyway, that's my obvious bias.
Other comments on 4? Any disagreement with what Bob said? Or other points of view, I should say. Okay, Roger?
Yeah, I concur with Bob. Just so I understand, in Erin's presentation and her other articles, around this theme of provider regulation incentives or a variety of strategies, those would be reflected in the document that finds its way to the commission, so they have a richer understanding of what we mean by item 4 or option 4. It's kind of a roundabout question asked.
You're asking, Roger, just to make sure I understand if that nuance, if the nuance of this discussion is going to be, exactly what was captured in the memo for FTAC's Medicare recommendations. Similarly, something will be put forward for ERISA. It's not black and white, and the nuance will definitely be captured.
Thank you.
Thanks, Angela. David?
I think Bob argued or described the economics well on number 4. I think I would anticipate that this would have to be done in conjunction with action on Medicaid, because I would imagine the provider community would not be initially excited about not getting paid the commercial rates that come through the self-insured plans.
Right. I think that's an excellent point.
You should throw Medicare in that also.
Okay. Okay, should we move on to payroll tax on employers? Christine.
Yeah, I just want to say that I struggle with this one compared to number 3, because it's paradoxical to me that this one is easier legally, right? But it also seems much more heavy-handed from the employer's perspective because they don't have a choice. And I wonder if maybe 3 is easier at the outset because it might be more politically acceptable and palatable to employers because they would be facing this choice. But then once you've passed it, then it's more subject to the ERISA risk. So I think we need to think about those 2 things. And, I think there's this 9th Circuit that came up that perhaps the ERISA risk isn't as big here in Washington because of that Golden Gate decision. But I don't know. I see Erin has her hand up. I'd be interested to hear what she has to say.
Yeah, Erin.
Yeah, so I think one of the things is that when I studied state single payer bills and state public option bills, there was a payroll tax in both, right? So a payroll tax isn't necessarily unique to one or the other. It is simply a financing mechanism for pulling employer spend into the state plan. And so then the question is about the ERISA questions are how high, whether there are exceptions, and and other things along those lines. There are also alternative mechanisms. In addition to sometimes payroll taxes, include income taxes, which would sort of mimic the employee-facing part of it, or premium payments from the employees or from individuals.
And we don't have an income tax here.
Right. So you'd have to that wouldn't be an option here, but sometimes they were structured as premiums, which also sometimes trigger some issues, but then avoid others. So so there are other mechanisms, but the payroll tax was again, isn't necessarily, I think to Christine's point, it really depends on how it's structured and not so much, it's not a distinguishing factor. It's not like a comprehensive public option doesn't rely on a payroll tax because you still need to pull those employer spend dollars in as well.
Mm-hmm. David.
Erin, I want to make sure I understand the basis for the payroll tax, and I may be a few steps behind everybody else, but I'm thinking that if I'm an employee of a self-insured plan, there's a chunk of premium, a big chunk of premium that's being paid on my behalf, and that money is flowing into the delivery system to cover my care. So is the point of the payroll tax to incentivize the provider, the employer, to stop paying that premium on my behalf and instead send it through the unified system?
Yes, so that's one mechanism. One is to simply capture those employer dollars, because you're absolutely right. There's a large amount of employer dollars that are currently flowing into the healthcare delivery system that you can't finance a state plan without somehow capturing that. And then the creation of a payroll tax is designed to sort of, one, literally capture those dollars, and then also pull people into, and their dollars into the state plan by saying, I don't want to double pay. I'm not going to also pay for premiums if I can get basically very good comprehensive coverage with a great provider network through the state, and I'm already paying for it through my payroll tax. So I think that's, yes, it's sort of like, think of it like Medicare, or, you know, like everyone pays in. Again, you can decide whether or not there'd be exceptions where you don't have to pay in, but basically it's designed to both pull dollars and incentives of people to move.
But am I thinking about it right theoretically, where if my employer said, oh, great, I don't have to pay that premium on behalf of my employee anymore, they could instead raise my salary, and then I could buy the premium on the individual market.
Yes. So for the employer,
okay,
it could be attractive in that way as well. And there are ways to structure it so that it is, you know, the employers also get preferred tax treatment on employee benefit spending. You could structure it in a way that it would essentially be similar for them to pay the payroll
okay.
tax.
All right, thank you.
Christine?
Erin, apologies if you already said this and I might have just missed it, but how does the state get out of the employer mandate if is it by a 1332? Can that be used? Okay,
Yes.
Got it.
I don't know if I have an example of a state getting a 1332 waiver for that purpose, but in theory, it is available for that.
Anything else on the payroll tax? Combination of two or more options. David.
Pam, if I understood Erin's presentation right in terms of the comprehensive public option, is that on here? Because that seems to me to be different than the pay or play number 3.
It's on 3. It's mentioned, and it's next to meaningful alternative, which could be the comprehensive public option.
Yeah, I see that there, but Erin, I thought when you described how to get to the public option, it involved a 1332 waiver. So is that one and the same in your mind? The comprehensive public option and pay or play are one and the same?
No, I think, again, I didn't include pay or play on the list. If you think about what, for example, the city of San Francisco and the city of Seattle did, that is not a comprehensive public option. So I would say that, yes, there's some daylight between comprehensive public option and pay or play. Could you structure a comprehensive public option to mimic a pay or play? Yes, but it's more than that.
Okay.
I'm going to comment on while I'm waiting for hands to go up, on the combination of two more options. If this 2, 3, 4, and 5 to me almost seem like a menu of strategies that could be used. And, I think to get to universal coverage, one of the things I like about this menu is that you could do things in the interim, particularly if you felt like a universal proposal was going to be challenged in court. So you could have moved forward on comprehensive universal care while you wait, because it could take 5 years to settle a particular lawsuit. So I mean, that's one thing. The other thing is that some of these things are really interdependent, like in being able to afford a system, relies on a payroll tax, relies on, getting a handle on provider costs and regulation of providers. So I'm just trying to think through how these all balance together so that you don't cross the ERISA line and that you reach the policy goals that the Universal Healthcare Commission has set up. Are there other thoughts about that? Oh, David.
I guess generally, Bam, I think you're on the right track. For me personally, I'd probably need a couple more days of discussion time to fully understand all the options and feel confident with a recommendation. But I think if the recommendation from us was worded along the lines of something that you said, pursuing multiple strategies simultaneously, continuing to get legal assistance and understanding the probabilities and perils that lie ahead, something along those lines feels more comfortable to me.
Yeah, and I know that Liz is taking notes, and I think there were some areas that we were pretty aligned on, which was the cost issue. I heard good alignment on that. The optional for employers to participate. So we'll start to get those. I think that Liz and or Gary could sum up for us, because we are getting really close to 4 o'clock, and that way we can kind of think through what that summary is going to look like. Gary?
So I have a suggestion, which is that the ultimate answer probably that you all would support may depend on aspects of the eventual solution that we haven't gotten to yet. Yeah. Right? We haven't created the entire we haven't decided whether it's a comprehensive public option. We haven't decided what the benefits are going to be. We haven't decided how provider reimbursement is going to work. So for purposes of ERISA, what I'm hearing is that there is thanks to Erin's great help, a consensus around the fact that it needs to be optional, that it needs to include provider regulation and incentives to deal with the economics of the system, and that there needs to be a funding mechanism that could be a payroll tax, it could be some other things, and it could provide exemptions for employers, or it might not, and we haven't quite come to decision on that. I think that's what I'm hearing. People should say if what I'm saying sounds right to them.
Sounds right to me. I found that very, very helpful. I would say that in number 3, there's a lot of devil in the details in number 3 in terms of payer, player, meaningful alternative, because the Universal Healthcare Commission hasn't filled in all the blanks yet that we need to know. Roger?
I saw several members nodding along with you, Pam, and Gary.
Okay, thank you.
And one last point that I want to make too is that I think that Roger's comment about bringing together the state purchasing is very consistent with the transitional solutions that the Universal Healthcare Commission has been discussing as a path.
Right.
And it's very consistent with the idea that we talked about some months ago, which is that if you want to ever get a federal government to agree to let you spend Medicare dollars at the state level, one way to demonstrate your capacity to do that would be to bring together the parts of the system that the state already controls and align them as best as you can. And they're not today. We know they're not today. So I think Roger's point does fit in with what we've been talking about.
Good. Roger, you have your hand up.
I do. Thank you for the support. With respect to we're looking at the federal waiver option this time, and we know that it's not available. The report that'll be generated by Liz and folks will share that obviously with the commission, so they know that that's it's more than a North Star out there to be achieved. I guess I would like to advocate for our commission, in its efforts to seeking what we know is going to be necessary legislative reform at the federal level, is again to, where possible, to work in harmony or work together with this newly established Oregon Universal Healthcare Plan Governance Board for our states, our two states together, to try to work in concert towards helping influence federal legislation that would grant ERISA preemptions. So I guess what I'm trying to say is the report would say that there isn't a federal waiver available today. It's going to require obviously some action in Congress and the administration, and a thought that we ought to be working with our sister agency, who is a little bit ahead of us, to jointly work on that effort together.
Okay. Other comments? Okay, I think we're at time. I think that was a really intense discussion. Aaron, this is my hat's off to you. This is an incredibly complicated legal field, and your mastery of it is very impressive, and it was a huge help to us. I'm going to ask Angela, just in terms of what we didn't get through in the agenda, will we be able to pin that to our next meeting?
Yeah, again, thank you, Aaron and Bill, for a fantastic discussion on ERISA. Our next topic was going to be Medicaid and sort of an intro and shedding some light on what the commission's guidance to FTAC is on Medicaid, but I do think we can do that via email. I know we have quite a few people on the East Coast here, and it's well past dinner time. So we can certainly do that by email so that folks feel prepared coming to the next meeting on Medicaid. Does that sound reasonable?
Yes, that sounds great.
Okay, great. We'll also, HMA will help us prepare an ERISA memo for the commission that FTAC members, like with the Medicare memo, will have a chance to review some of the nuance that was captured in today's discussion. So keep your eyes out for that too, in the next probably 2 weeks or so.
Yeah, that'll be really important that we each review for how it captures the conversation. Okay. All right. Well, with that, I would like to thank everybody for their time and participation. I think this was an excellent meeting as usual, and I look forward to getting together again in a couple months. And please look out for that memo to review, and I'll be working hard to convey what we discussed today to the Universal Healthcare Commission. Thanks, everyone. And thanks to staff for helping support us through this.
Thank you. Thanks, Pam. Thanks, everyone.
You.
Bye-bye.
Take care.